Dr. Petteruti. And he's going to go ahead and give you a little introduction to himself, because I felt like this did not necessarily do him justice. So, and I said, you know, you really know yourself better than this piece of paper, so I'm going to let him do that. Are you mic'd?
I'm not mic'd.
Okay.
I'm going to hold this one.
Yes, thank you so much.
Thank you very much, and thank you for having me here. It's a real honor to be speaking to you all. I'm Dr. Stephen Petteruti. I'm a family practice physician. I've been involved in functional integrated medicine for the past 10 years. Back in Rhode Island, I have a practice that incorporates hormonal therapy, functional therapy, medical weight loss. I'm board certified in obesity medicine, and have been studying with the American Academy of Anti-Aging Medicine for many years. I didn't start out wanting to treat cancer patients. I was sucked into it because they're out there, and they're coming to see you. And at the end of today's lecture, you're going to have some extra tools, if you don't already possess them, that you can apply when these patients cross your door. You'll be comfortable engaging in mistletoe therapy. If you have an IV center, you'll be able to pursue IV vitamin C. We're going to talk about the role of adiposity in cancer recurrence. So I agree with my other speakers that this is a chronic relapsing condition. We'll also talk about liquid biopsies today, right? We need to learn about late recurrences. These are the things that happen after 5 years. The liquid biopsy technology is evolving. The problem is, how do we use them? It's a real challenge. The role of IV vitamin C, subcutaneous mistletoe. Subcutaneous mistletoe now can be sourced in the United States. It can be applied by any medical practitioner, chiropractors, nurse practitioners, naturopaths. It's not a prescription drug. There's one source that supplies it. I can say that because it's the only one in the country. Uriel Pharmacy, U-R-I-E-L. And they will only supply it when directed by a clinician, even though it's technically an over-the-counter drug. 5 years is not enough, can we agree, right? 5 years. Hooray, you're cancer-free. That's a good thing. But you know, I'm 60 years old. If you told me I had 5 more to go, I'd rebel. I want a little more than that. The late cancer recurrence imposes on our patients fear of cancer. This is a documented condition, psychological in its origins. The treatment of which I maintain is to address the underlying risk of relapse. Give a patient an evidence-based pursuit of things they can do to prevent it from coming back, rather than idle hope. So you want to do counseling, that's cool, but you got to take action. Fear of cancer is because the risk is real. Watchful waiting in the face of cancer is intrinsically stressful. I like the doctor's recommendation for a 90-day sabbatical. I want that ticket. And I don't know, 90 days, I think I'd go nuts sitting around. I need 90 minutes. See, like right now, I'm the thing between you and a glass of wine. This stress is going to build over the course of today's lecture. So, doubling time. This is at the cornerstone of the cancer relapse story. Now, you heard earlier that cancer that grows to the size of 1 centimeter possibly has been there for 10 or more years. It's true. It takes approximately 30 doubling times for cancer to acquire the size of 1 centimeter. With breast cancer doubling at, and you see the range, and pancreatic cancer at a slightly faster range, can take years. And that's one of the reasons why we do see late recurrence. The cancer stem cells float about. Many of these cells are senescent. They're not dead, they're just not actively dividing. Well, if they're not actively dividing, they're harder to kill. And I'm of the opinion that it is a chronic disease and that it does relapse, and it relapses at times of vulnerability, when our stress level rises and our immune system takes a break. And it sneaks in that window and it can explode in our face. Chemotherapy can select out stem cell resistant cancers. So here is a very important study in the New England Journal of Medicine. These are all in your slides, so you can pull the references up. They're talking about 5-year recurrence of breast cancer. These are women who've had breast cancer, stage 1, T0, surgically excised, no chemotherapy. After 5 years, 13% risk of cancer relapse. 13%. People perceived to have been cured. It's extraordinarily high. And when it comes back, you don't know where it's coming. The bone, the brain, the other breast. What do you scream? And it's difficult because by the time you see it the second time around, and I'm sure many of us have had this experience, of a patient or a friend who had breast cancer, had it cured. 20 years later, they have 6 months to live. Pediatric cancer, a huge demand in this arena. Those of you that are comfortable treating children, nobody needs secondary prevention more. And you can see the relapse rates. Now, we made great progress with people, oncologists, I'm not an oncologist. Oncologists have made great progress with pediatric cancer, and you can see the rates of delayed relapse. They are diminishing. This is largely because we've decreased the amount of radiation and chemotherapy in pediatric cancers. So we lay the ground for this late recurrence by virtue of the treatment itself. Radiation is carcinogenic. Distant recurrence happens not only in breast cancer, but in colon cancer. And I maintain in just about every type of cancer. In addition to recurrence of primary cancer, there's recurrence, I should say, a reoccurrence of new primary. So you can have the primary cancer come back, or you can have a new primary cancer occur. And one of the risk factors for getting cancer is ever having had it. So what can we do? There's so many of these patients will come to see you in functional medicine, and they want to know, hey, what can I do to prevent this from recurring, doc? And in my practice, we've started to use some liquid biopsies. This is testing blood to determine evidence of cancer. Now, there are tumor markers. The problem with most tumor markers is that they tend to occur late in the process. Now, in the world of lab testing, as many of you know, there are kit tests that are FDA approved. You want a PSA test, it's a kit-based test. Any lab can draw it and do it. And then there are specific lab-developed tests that are unique unto a certain lab that have been FDA cleared for the use only of that lab. And these are proliferating very rapidly. And it's a bit of a challenge since it's difficult to know which lab to order and then how to interpret the result. So I'll share with you what I've adopted, and this is certainly a fast-moving field. Circulating tumor cells. The company that I use for this test is called Biopsy. It's the only company that does their particular test type. And I had a patient with prostate cancer. He had a primary treatment for it. He now feels well. His PSA is at a plateau, and he had a circulating tumor cell test for prostate cancer that came back positive. Now there's a challenge. He feels great. He's already had primary treatment, and his CTC is positive. Circulating tumor cells are hard to measure. It's technically challenging to acquire them. A negative test doesn't put your patient out of the woods. A positive test is something you can maybe use to formulate treatment, as we'll talk about. Here's my preferred liquid biopsy. It's a methylated DNA. Why? Because methylated DNA is easier to acquire. The methylation of cancer cells has a unique pattern that's different from normal and healthy cells, and it sheds more prevalently into the bloodstream. It's easier to catch. IVG recently, I think in the past year, has pioneered this test, and I've used this with some help and guidance. They have a test for colon, breast, lung, and one other cancer.
And melanoma?
Not melanoma.
No.
Not melanoma, but they're developing others. These tests have not been validated. They are not screening tests. They don't take the place of regular cancer screening. They're a tool in the toolbox for you guys, for us, the functional docs. Why? Because this is a test that, and you can see why, mainstream oncologists, wonderful people, heartfelt, essential, but when it comes to secondary prevention of cancer, the calling comes out to you. The oncologists have done their work. Now the patient has a life to live. Another type of test, this one, the oncologists don't know what to do with these tests. Why not? Well, imagine you're a perfectly healthy woman, you had breast cancer 6 years ago, you come to see your functional doc, they do an IVG methylated DNA test, comes back positive. I mean, what do you do next? You feel great, you have no tumors, your mammograms are normal, you do a PET scan of the whole body, it's normal. I maintain, and I think there's science to support, the studies are in your slides, that when the cancer is dividing on a cellular level, it's much more vulnerable to be killed than when it forms a tumor and now has a full defense mechanism. It's a Death Star at that point, right? It's a centimeter in diameter. It's been there for years. Well, this is just unsettling. This is where vitamin C intravenously can be a great asset. If you use it in your practice, good for you. Expand its use. So where does it come from? History. Dr. Pauling was a pioneer in the thought of vitamin C for cancer. He noted that in scurvy, it had attributes similar to cancer in that it would eat through tissues and organs. Cameron and Campbell saw encouraging results. Survival benefits were thought to occur in other studies, people living longer than expected with cancer. This came to a screeching halt in the late 1970s when the Mayo Clinic did a series of studies looking at oral vitamin C. Take note, oral vitamin C at high dose. They concluded vitamin C had no value. This is where many orthodox oncologists have paralyzed their memory. Dr. Levine out at the NIH then did studies confirming there's a difference in blood level, I'll make sure I don't fall off here, a difference in blood level between orally administered and intravenously administered IV vitamin C. The vitamin C given orally plateaus at about 2,000 milligrams a day. You can't get the blood levels to go up any higher. Is it safe? So in our world, in the functional medicine world that I inhabit in my center, number one, it's got to be safe. If we're going to do stuff that's avant-garde, we have to know it's safe. Number two, it has to have a plausible mechanism of action. We don't need evidence-based proven outcomes. That may take decades. We need evidence-supported rationale. Vitamin C has that. And number three, it has to be practical. We don't have the luxury of tagging an insurance company $100,000 for a treatment. So it's got to fit. Vitamin C hits all three criteria, as does mistletoe. Risk of kidney stones, I'll tell you, we've done over 15,000 infusions at our center. Many, many high-dose vitamin C. Yes, people get thirsty. Sometimes their sugar dips a little bit, easy to treat. We're waiting for our first kidney stone to happen. I just jinxed myself. Well, hopefully it never will. Extraordinarily safe. Phase 1 trials are out there. They're in the literature, and it's been proven safe. Mechanism of action. So initially, Dr. Pauling, Linus Pauling felt it was due to collagen enhancement that the vitamin C would create a shell around the cancer that would prevent it from metastasizing. Subsequent studies have then drawn on the focus of hydrogen peroxide theory that intravenous vitamin C becomes pro-oxidative, not antioxidative. So your oncologists that are nervous, they'll tell the patient, don't do vitamin C, it's going to neutralize chemotherapy as pro-oxidative. It's going to neutralize a chemotherapy, it will not. In almost every case, it is supportive and amplifying of chemotherapy. It is radiosensitizing if they're getting X-ray treatment therapy. It's tough. You know, we were talking about stress with our cancer patients. One thing that we never do, and I encourage you not to do, is put a patient in between you and an oncologist. It's a tough spot. So I have some patients, the oncologists are very thick-necked people in some cases, and they say, absolutely not. No vitamin C, it's going to harm the chemotherapy, it'll mess with my protocol. The patient can't be put in that squeeze. So we always send a letter to the oncologist, letting them know what our treatment plan is, what we're proposing, and hopefully what we hope to get from the oncologist is just acceptance. They're really not in a position to endorse what we do in functional medicine, but it's cool if they just say, hey, it doesn't seem to cause harm, I don't object. And I'm seeing more and more of that kind of response. Okay. Dose and frequency. We dose it based on fingerstick blood sugar. This is from the work out of the University of Kansas. Better get that, it sounds important. Your pizza will be there in 10 minutes. University of Kansas. And in reality, we don't know the exact dose. In Europe, they tend to cap their doses at around 7,500 milligrams. You'll read in the literature doses up to 100, 200,000 milligrams. Here are some practical barriers. Cost and time in the chair. So a rational cutoff was established by Dr. Driscoll and colleagues along with Dr. Levine, and they found that a fingerstick blood sugar differential was a good correlate to measure the blood level of vitamin C. It's difficult. You cannot draw blood vitamin C and send it to Quest Lab, it will come back skewed. It'll come back skewed because it degrades quickly. But vitamin C has a molecular structure that is so much like sugar that it fools a glucometer. So a tip to your people that are, if you're doing intravenous vitamin C and they're diabetic, do not trust your glucometer for 24 hours. So you can do a resting, that is when they arrive at our center, we do a finger stick, and then we do it at the peak of treatment toward the end of their IV infusion. If there's a 350 milligram per deciliter differential, we consider that therapeutic, and that becomes their dose. And I would say the vast majority of them dose up to about 50,000 milligrams. We usually hit the bell. Smaller people sometimes lower. So how do we go about frequency of dosing? Well, remember the doubling times. Even the most aggressive cancers are going to have a gap in doubling time. We advocate secondary prevention. Secondary prevention is somebody that comes to you, doctor, I had cancer, they gave me chemo and radiation, it was 4 years ago, I'm cancer-free, I feel great. Then the secondary prevention conversation can take place. And based on those doubling times, it's rational to consider doing this once a month. The only thing that they risk, time, money, the consequence medically is trivial. If they're willing to accept the possibility that this can afford them benefit, that's great. I make it clear that we don't have proven outcome evidence yet, but we have favorable case studies we're developing. Moving on to obesity. If you're doing anti-age therapy, you must have an approach to managing obesity, right? Nobody gets to live the 100-year lifespan. We shoot for 120 at our center. We like to be a little ambitious. We call it IM 120, Intellectual Medicine 120. Well, somebody said, well, why that? It was actually my lawyer. I said, what do you put it how you make an unreasonable guarantee? Well, we know about the half-life equation, correct? And now we know Genesis, man shall live to be 120. Not bad. And then we have physical evidence of people living to be 120, but you got to avoid the big three. Number one, you don't die young from a heart attack. Number two, you don't die young from cancer. Number three, you don't get demented. Fortunately, they all have a common denominator. It's obesity. So whatever you're doing for managing obesity, good, keep doing it. If you're not sure what to do, then get a solution and bring it into your office. Excess body fatness. Cancer rates for colon cancer are going up, pancreatic cancer is going up. Heart failure death rates are going up for the first time since 2017, and it correlates with the obesity issues at hand. Weight loss cancer risk, this is from the Women's Health Initiative. This just correlates a reduction in body weight with reduction in cancer risk. So when we see patients that have had primary cancer, we put them on a body analyzer. Our target for women is a percent body fat less than 35, for men less than 25. More ideally, it'd be 30 and 20 respectively. We feel that's what we like to call healthy heavy. Prostate cancer goes up. I will give you this caveat as well. Prostate cancer should not be treated. I cannot think of an orthodox treatment for prostate cancer that is worth doing. In my opinion, the treatment is worse than the disease. There's the PIVOT study, which looked at cancer patients with prostate cancer patients, even those with moderate level disease, Gleason scores of 9. One cohort, these are biopsy-proven cancer patients. One cohort had their prostate removed, the other did nothing. 12 years later, the death rate's the same in both groups. 12 years later, the death rate from cancer, prostate cancer, was the same in both groups. There's now in the literature this evolving approach called watchful waiting. It's a fancy term for doing nothing. That's kind of harsh, but it's better than doing something, right? Don't just do something, stand there when it comes to prostate cancer. But you guys now can step into this arena. It's great that you have the tools to do it. This is just a quick summary of obesity, another chronic relapsing disease. A temporary treatment for a persistent chronic relapsing condition is a folly and irrational. Whatever you do for obesity, don't stop. And this is from Tommy Wadden and colleagues, University of Pennsylvania, and it summarizes the outcome of just about every known diet. Initial weight loss, ultimate weight gain. You can overlap any diet here you want. I don't care if it's intermittent fasting, ketogenic, you fill in the blank with a diet, it's going to fail. You integrate permanent nutritional change with supplement support and pharmacology, you got a shot. Mistletoe therapy, it's kind of exciting stuff. It's the #1 integrative cancer treatment in Europe. It's big in Germany. They have hospitals where it's integrated right in the oncology ward. Only within the past year has it become sourced within the United States. Prior to that, you had to smuggle it in from Europe or Canada. Patients would sneak it into my office and we teach them how to administer it. Tumor growth inhibitor, immune stimulation, it works also by direct toxicity to cancer cells and relief through its lectin formation. Mistletoe can be administered subcutaneously. So at our center, we do a mistletoe test, which is a small dose subcutaneously, observed for allergic reaction for 48 hours. Nothing bad happens, then they come back in and we do a teaching encounter. We teach them how to inject it subcutaneously. There's a website that's worth knowing about. It's called Believe Big. First word believe, second word big. The originator of it is a woman who had terminal colon cancer, 4% chance of living. She researched her own options and found mistletoe, started administering it, and here she is 10 years later leading this organization. She raised over $1 million to fund an NIH study that's underway right now for mistletoe and cancer. But here's the thing, right? Why do we do what we do? We have to do it now. We don't have 10, 20, 30 years to wait for these outcomes, and we need to take action now. So mistletoe is very exciting to me because it's so inexpensive. I'm sorry, question? Somebody amplify that question for me.
What was the website?
Oh, the website is Believe, like in Believe in Santa Claus, and the second word is Big, like I have a big head. All right, so Believe Big, and it's Ivelisse Page is the woman behind that movement. There's another resource worth knowing about. It's Eric Marsden, Dr. Marsden, M-A-R-S-D-E-N. He has an online training for mistletoe therapy that's quite good. And feel free to contact me as you move forward if you're interested in implementing this as well. It can be a little bit intimidating at first, but once you get your chops down, it's easy to do. And it's great, you know, we heard from other speakers, they're all doing beautiful, fantastic things for their patients. But I don't want you to feel overwhelmed that you need an army. Sometimes you're an army of one. Sometimes you're it. And there are too many cancer patients out there with too much need, with a wide range of fiscal capacities. And this mistletoe is fabulous because of that. Okay, this is mistletoe cancer prevention in bladder cancer. We're seeing studies showing efficacy. So here's an important quote. We talked about watchful waiting. We talked about it as a harsh prescription. And we need to then take watchful waiting and turn it into tangible action of merit. And that's one of the things we're advocating for in functional cancer therapy. There's a void. I was intimidated by cancer patients. They scared me. I didn't want to touch them. I didn't know if the oncologist would get mad at me. I didn't know if what I was going to do would harm them. It's taken years. And many of you, I'm sure, are further down the path than I am now. And it's great that we're here sharing these ideas. So we can take action in any form of cancer. And here's some case studies, patients we've had in our center that have taken advantage of the secondary prevention philosophy. Or in the case of prostate cancer, I advocated as a primary therapy. Quick story about prostate cancer. I have time? Doing okay? Yeah. So I had this gentleman, he came to see me. At the time, he's in his mid-70s. His PSA runs about 58. And he said, when I was 52, I was diagnosed with prostate cancer, and they wanted to take my gland out. He said, I'm not going to do that. And the oncologist, the urologist, went nuts. He said, you're going to die. This is a death sentence. He said, I might die, but I'm not losing my prostate. He had a 30-year-old girlfriend. He had no interest in his prostate coming out at all. The doctor subsequently has died. My guy's still alive. He's had prostate cancer for 20 plus years. His PSA is astronomical. He's 75, he works a full schedule. He now has a 50-year-old girlfriend. He feels great. A living example of the watchful waiting paradigm that is being promoted. Now, I maintain that the watchful waiting is a little bit harsh to do, and we can offer them something better. But here's a kid with Ewing sarcoma, metastatic to the lung, to the iliac crest, given a 15% 5-year prognosis. These are some stats on survival from Ewing sarcoma, horrible disease with an aggressive pattern. Late complications. 84% of these patients have late complications. We talked about new primaries. We also talk about disability, adverse effects. This is seen in 2015. Now, Mom did the research and came to us because she was interested in doing something more for her son to help with his cancer. And you'll find this frequently. Patients will come to see you because they know maybe you do it IVs. We did not open up our drip bar hoping to attract a lot of cancer patients, but now we treat them out of demand, and we become more expert in it by virtue of their need. So we started him out at 5,000, titrating up to 50,000. Now, Ewing's is very aggressive, so we treated him once a week, then we dropped it back to every 2 weeks, and then in a maintenance protocol. Another thing worth knowing about, if you have an interest in treating pediatrics, Haven's Healing Hands, that's 3 H's, is a charity that will pay for the treatment. Last check. Feels great in high school. Another case study, breast cancer. So we've got a case of pediatric malignancies. Talk about scaring you, right? Cancer and pediatrics. And functional medicine, you mix it all up in the same pot. Very terrifying. So the informed consent dynamic is so critical. Because what's more important than science is philosophy. And we're going to highlight that in some of the latter cases. I got a couple more to do. The breast cancer, rare type. So this woman had a tumor. It's about 4 centimeters in diameter. It turned out to be metaplastic, triple negative. Her doctor said, listen, we don't know what to do with you. Chemotherapy doesn't work for your kind of cancer. Radiation is limited benefit, but we think you should do chemo. Well, that's the only thing they had to offer her. And with a 60% chance of recurrence, to say to her, we have nothing, would be a little bit harsh. So she weighed the pros and cons. We had extensive conversations, and she decided to do a combination of mistletoe and vitamin C. Whether or not this ends up helping her, well, I can tell you it already has. It already has because she has a rational treatment pathway. It already has because she feels great. Chemotherapy would have been a guarantee of adverse effect with an uncertain benefit. Now, in my center, in my world, like yours, if there's a chemotherapeutic pathway of high value, we encourage patients to engage. It's not a competition between treatments, yes? It's a synergy. It is a collaboration. And we look for our oncologic colleagues to work with us as much as possible and for us to encourage our patients. I have a patient right now, she has lung cancer, and she refuses to do anything. No surgery, no chemotherapy, nothing. She has adenocarcinoma, it's treatable. This is a dilemma for us, yes, because we now have a patient that says, I want to do vitamin C, I will not do chemo. Do you treat or not? I opted to treat her with reservation, documenting my advice that she was neglecting herself and that she would likely die from her cancer, absent a full range of aggressive treatment. And she's going to get more imaging done. In fact, she'll get it done next month, and if her cancer progresses, she might consider engaging in conventional therapy. A lot of patients come to you and to me because they're afraid of conventional therapy, and sometimes we can bridge that gap. Here's another case, a 53-year-old, that's not DCS, she had invasive ductal carcinoma, triple positive. That's a relapse risk based upon the New England Journal article I shared with you. Completed chemo, x-ray, started hormone suppressive therapy. Unquestionably will reduce her risk of recurrent breast cancer, right? Stats are irrefutable. However, brain fog, joint stiffness, low libido, vaginal dryness, and low energy. Told by her oncologist, get used to this. This is what happens. This is the new normal. We can send you to a support group. You'll learn how to cope. You can use vaginal lubricants. You'll have to rest. She said, whoa, time out. I'm not going to live that life. Stops hormotherapy. Decides to add vitamin C monthly. We used intravaginal E3 and testosterone to help with her sexual dysfunction and her vaginal dryness with great benefit. We did an IVG blood biopsy that came back negative. None of these tests are rock solid, but it's pretty comforting when you see that, and it's a metric you can follow because it is linear. Philosophy beats statistics. Simply put, she's made a choice to accept a high risk of cancer relapse in exchange for the benefit of living great right now. And that's her prerogative. As long as we do our job properly, as long as we counsel them properly, then we can engage in that journey with them. It's great having this tool in your toolbox. If you're doing IV vitamin C, I would never say to this patient, yeah boy, don't worry about that tamoxifen. The IV vitamin C's got you covered. I tell her, I don't know. Right? We know its mechanism of action. We have a theory. We have a possibility of benefit. But you have to live with the consequence. And that consequence, I frame it out. If you do the tamoxifen and in 10 years you get breast cancer anyhow, how are you going to feel? We call that the philosophy of regret. And you want to go to your sweet night with as few regrets as possible. Conversely, if she does all the things that we're doing, chooses not to do tamoxifen, and gets breast cancer, how would she feel? Well, my patients will tell me, I'll feel great as long as I lived well. And that seems to be a recurrent theme. Quality over risk of disease. If I'm feeling great in the moment, and I will accept an uptick risk, I'm good with that. I can tell you that I put patients with prostate cancer on testosterone therapy. The Batman study out of Johns Hopkins University is exploring this dynamic. Dr. Morgan Taylor is exploring this dynamic. The evidence is not in. And we do so this slowly, carefully, and with extraordinary consultative support. And it all turns on the patient-based philosophy. So in summary, philosophy trumps science when it comes to these decisions. Science is relevant because it helps inform philosophy. Our job, my job, I feel your job, is to take these patients and give them the time they need and the information they need to balance all of these decisions. Oncologists are slammed busy. This is not their field. They need your help. The patient that is trying to assess functional attributes, whether they're going to be on hormonal support therapy, patients with breast cancer may make that choice. They need your guidance, and they need your support to get through it. So I hope I've left you with a couple of thoughts and ideas and practical things you can do. I'll take any questions. Yes?
I just have a question. These are active cancer patients. Do you have like studies on like 10 years later, 5 years later, like case studies that you have? So I have a case, adrenal fatigue, et cetera, teenager who had Hodgkin, non-Hodgkin, and then in her 30s, she's tired all day, thyroid hormones, et cetera, but there's really no protocol for them in oncology for like an actual follow-up. We just know they're at a risk for everything else. So would you implement that mistletoe and IDC in these patients who are already supposed to be on remission? So this for active cancer.
So the question, somebody that has already had their active cancer, what's the evidence 5, 10, and 15 years out? There is none. What we're doing is innovating a treatment approach based upon biological mechanism of action and based upon what we know about relapse rate in the absence of any intervention. We talked about some of the liquid biopsies. What we know is you can't stay on chemo. Of course, that'll kill you. We know that there's a high risk of relapse of malignancy and other secondary conditions, and that many of these patients require your support. And the whole range of modalities that have been outlined here today, not just vitamin C and mistletoe, but hormone support, nutritional support, quality of life support as well. Great, we have a panel up here. This is awesome.
Yes.
So I have a question though. Dr.
Yes.
Patel?
Patty.
Patty. Dr. Patty, when you do progesterone therapy for cancer patients, do you administer it orally or topically?
Orally.
So it's administered orally, and you do it for men and women both?
Yes.
And what's the dose range for men?
It used to be 6.25 to 50, but over the last 10 years, we see so much adrenal insufficiency that the dose for men has gone up. So I'm starting at 12.5 and up.
Thank you.
There's actually a great study that shows that the oral progesterone, we talk about the cream progesterones, but the largest study done by the French cohort, they used oral progesterone, and their rates actually went down slightly, maybe not significantly, but it was lower. We're all here for questions.
Any other questions? In the back of the room, nice and loud.
You said even sealing hands is the one that provides monetary support for pediatric patients?
Can you repeat again?
Haven's Healing Hands.
Yes, Heaven's Healing Hands.
Oh, yeah. The charity for children is called Haven, H-A-V-E-N-S, Healing Hands, and it was established by a woman in Massachusetts who saw a great benefit to her son when receiving vitamin C intravenously. One of the problems when you have a chronic disease that's relapsing is you cannot go to Mexico for 3 months, get whacked with vitamin C every day for 60 days, drop 40,000, come home and live happily ever after. You must have a local resource. You must have a relationship with somebody who has your skill set, and it's got to be open-ended. And then we've got to have a range of approaches that fits their budget and philosophy. So Haven Healing Hands, if you contact them, they will pay 100% of the cost. Yeah, it's a cool thing. Yes?
You made a great analogy with the prostate cancer. That all of you can transfer that over to the early stages of breast cancer, the atypical cell
So transferring the watchful waiting paradigm from prostate to breast cancer will be the topic at the next conference. This is huge. I'm going to say a word and then I'll pass it off because they probably know more. Certain types of breast cancer are felt to be indolent and may be better not treated aggressively. Psychologically, I think it's impossible to tell a woman, you have an indolent breast cancer, we're going to do nothing and hope it doesn't grow. Putting mistletoe and or vitamin C and or a lifestyle into that equation is certainly an option, I think.
So the prostate is analogous to the uterus, and so using the theories that the uterine and breast cells are similar, I would say the same thing. It has to go with methylation with prostate cancer. Interestingly, I showed you my genetics. My dad had prostate cancer. So my mom didn't have uterine or breast, and my bad genetics are from my dad. So there is a correlation with estrogen, and it's not testosterone, it's estrone in these men. Estradiol potentially, so it is poor methylation, poor estrogen detoxification. So a prostate cancer patient I would probably treat the same way. As far as your question about watching and waiting for breast cancer, I agree with you. I don't think there'd be many patients that would do that. I completely agree with your approach to that. I would never tell a patient not to take tamoxifen or not to do therapy, and that it's our job to partner.
I have an answer about the watchful waiting, and it kind of goes to the question that you had asked. We offer every single patient, whether they've had cancer, they're trying to prevent cancer, they're trying to correct their diabetes, they're trying to correct their hypertension, or they're just trying to prevent a cancer, the 5-point model, where you're measuring the hormones and optimizing them to the 75th percentile, especially focused on the adrenals because of the chronic stress response. Measure the nutrition, do the same. Detoxify the body, identify any toxins, get them out. Mind and physical body. And when you do that, as I was saying in our practice, we've taken care of continuous patients for 15 years, and in 10,000 patients, we literally have 12 cases of cancer, and 3 or 4 of them came in within 6 months diagnosed. So there's prevention and prevention of recurrence because it's working on epigenetics to turn off the promoter genes and turn on the suppressor genes.
That's a beautiful approach, and I want to emphasize that all these approaches are linked and that nothing is exclusive of the other thing. Yes?
Prostate cancer treatment with the use of testosterone, I'm familiar with it when your traditional hormonal depletional agents like Iodine and Efudex, when they fail, which they eventually do, and then the PSA starts to rise significantly, at that point adding in testosterone. So I wish you'd comment on that. And also, just one last thing, and that is, I commonly use 5,000 milligrams of vitamin C as a primary care guide for urinary tract infections. Spread through the day, patient tolerance, no issue. And I just wanted you to comment about using that in addition. So once you give them the IV therapy and it's interspaced, can they continue to take high doses of oral vitamin C along with it?
So in order, the prostate cancer testosterone approach is not established treatment. It's experimental. It is has enough, I think, scientific basis that if you choose to engage off-label with a well-counseled patient, it's not unreasonable. I do not think there will ever be significant research on that treatment pathway because testosterone is generic and nobody's going to pay for it. Okay? So I think functional docs may engage. Now, the other question you had was about oral vitamin C. We maintain concurrent supplements, so imagine when Dr. Patty's patients came to see me, we would defer all that other work because it's so great. Maybe add in vitamin C or mistletoe. However, the caveat is this. On the day they get their high-dose vitamin C, that morning, you skip all your antioxidants because theoretically you may neutralize some of the pro-oxidative effect. And you do not put glutathione on an IV vitamin C day. That's something you do on a separate day. So yes, to higher dose. And just because the blood absorption level caps at about 2,000 milligrams does not mean that that's the extent of benefit. So we're all familiar with the lipomicized vitamin C and its benefit in the gut. Higher dose can have merit. In the white shirt, yes.
Yes, I tell cancer sufferers they can choose to believe that cancer is a terrible thing, or they can choose
That's a
Yeah,
beautiful
very good
phrase.
point. Yeah.
Beautiful phrase. You know, we talk about the rectangular lifestyle, and that's what we're all seeking for our patients, right? So I had a patient, quick story. She came to see me, she was, and then your question, getting weekly vitamin C. She had stage 4 metastatic breast cancer, and she said, Doc, I'm thinking of going to Bulgaria. I said, Bulgaria? She goes, yeah, they do oxygen immersion therapy. And I had to say to her, you can't go to Bulgaria. She said, well, why not? I said, because you only have a couple of weeks to live. So what do you mean? She was yellow, her liver functions were off the chart, she had tumors every place. The point of the story isn't awful that she died, isn't it great that she felt so good? You know, and I believe that her vitamin C regimen was an element of that. I'm got a question as well.
I have a question for Dr. Patty. What level of pH do you want for a cancer patient? And do you use devices to structure the water, such as do the company Gia Wellness has things that help to do that?
Yeah, so as far as the pH, what...
Can you repeat the question?
The pH, he's asking where we want the pH, and we ask the patients to check the morning pH of the urine, and we want it above 6.7 to 7.4, somewhere in that range. If they hover, it's fine. If they're below that, you load water, pink salt, or polar mints, which is potassium-based, lemon, okay, and possibly some bicarb. But if you cannot get that pH up, you can guarantee yourself it's because there's an infection somewhere. And you will detect it if you look for it, and it's usually right in the mouth. That's the long-term thing. If you don't, you know, by doing basic 5-point model type thing, you're already hitting infection, but you have to go after it actively at some point. And then as far as structuring the water, there's so many things you can do. There's great studies showing that you can just bless your water and it'll be structured. So I think the devices, you know, I can't tell you that I know a specific device. I do use certain types of things for water. I use molecular hydrogen water. I use crystals in my water. I mean, you know, I don't want to say there's any science to what I'm saying right now because I don't know the answer to that question. But yeah, go ahead.
Do you use DIM, dietary method, in any of those?
Very actively, yeah. When you look at the pathways, like you can use a lot of different things, but DIM, TMG, MSM, I find, you know, frankly, even using high doses though, I don't find that you can really turn those pathways into the better pathway unless you simultaneously work with the liver and the bowel and things, and I don't know what your experience has been on.
So the only time I wouldn't use it is there's a few patients that can't tolerate it if they have problems with their sulfation, just because of the sulfur base of it. And also I have some patients that have a SNP of 1A1, so they already are pushing down that pathway. So it's not that DIM would be harmful, it's that if they have a certain amount of money to spend on supplements, you might want to give them something else like the resveratrol, but it would not be harmful. And some people think everyone with dense breasts should be taking DIM.
Any role for iodine in prevention?
So the question was iodine for the prevention of treatment of breast cancer. So there have been some studies that show a correlation, and there's some patients that treating with iodine helps their benign breast disease. But again, remember, if you take too much iodine, you can get hyperthyroidism. So usually some of the studies show that after 6 months of supplementation, you can reach saturation of your iodine stores. So now we have, you know, ways to measure without doing the traditional urine test and the loading. We have dried spot urine, so you can monitor that. But there is a role for using iodine in that patient.
I think we had a great session. Thank you very much. I don't know if any of us maybe will still be here if you want to approach us, but God bless you and have a absolutely wonderful, vibrant, joyous moment finishing out today.